On behalf of the Servants of the Holy Heart of Mary, I want to thank you all for joining us this evening for our program, Mental Health and Supportive Family Relationships. Our speaker this evening is Dr. Valerie Maddie, but before I introduce our speaker, I'm going to introduce myself. My name is Susan Amen. I'm the Director of Spiritual Ministry for the Servants of the Holy Heart of Mary. It's wonderful to have Dr. Valerie Maddie back. Dr. Valerie Maddie is the Associate Director of Family Ministry at the Diocese of Joliet, where she oversees the hurting and healing ministries, including providing care to those who are divorced, widowed, bereaved, or going through an annulment process. She's also an art therapist and psychotherapist at Labyrinth Counseling Center in Naperville, Illinois, where she specializes in treating trauma across the lifespan. Welcome, Valerie.
Thank you, and welcome everybody. Can everybody see me okay? Thumbs up, just let me know. Great, okay, good, and everybody can hear me okay, right? I think there's nothing worse, right, than going to a presentation you can't hear someone. So please use that chat or unmute and at any time during tonight's presentation and let us know if we can help you, okay? I'd like to begin in prayer first, and then since we are a small but mighty group, I'd like then to open up the floor for any introductions. I'd like to know who I'm meeting tonight and presenting to. So please join me in the prayer tonight. I'll put it up on the screen. In the name of the Father, and the Son, and the Holy Spirit. Loving God, we pray today for those who are comforted by the sadness, ambiguity, and confusion of mental illness, and for those upon whom they depend for attention and compassionate care. Look with mercy on all those whose afflictions bring them weakness, distress, confusion, or isolation, and provide for them homes of dignity and peace. Give to them understanding helpers and the willingness to accept help. We ask this in the name of Jesus Christ our Lord. Amen. Okay. Well, thank you for everybody who is here tonight, and we're going to get started. Everybody can still see and hear me, correct?
Mm-hmm.
Okay, great. Before I begin, let me just give you just a slight overview. I hope to share with you a little bit about mental health conditions, mental illness to be specific, and I'll be using a lot of resources as we go through the slides. The slides will be there. We are recording, just so you know. So, you know, it's going to be there for you, and you'll have it in the future when Susan uploads it. So she'll be able to give you that link in the future. So I really hope that you can just take in what you can and just know that if you need to look back at it again, it'll be there for you. But after I give you the overview and talk about a little statistics, which is really important as we're working in managing mental illness and learning about it, then we hope to go into the effects on the impact on families. And then most importantly, what can we do? Because it's good to know the background, and then we need to know practical ways of how we can respond, how we can manage it perhaps in our own lives, or come up alongside and help someone else. So let us begin, and I'll try not to get too technical, but remember, there's some statistics in the beginning that I think are really important. So according to the National Institute of Mental Health, there's an estimated 46.6 million adults age 18 or older in the United States. This is according to their survey of 2018. There'll be a new one coming out soon. What they consider and categorize any mental illness, or for short, AMI. So that might be easier for you to remember, right? And this is a mental, behavioral, or emotional disorder, according to the National Institute of Mental Health. And so what's important is there's a difference between a medical condition and a mental health condition or mental illness. And the National Institute of Mental Health shares these statistics and breaks this down for us so that we can understand it a little bit better. AMA is higher among women, according to 2018, right? 22.3% as compared to men, 15.1, okay? Let's look at that next box together. Young adults ages 18 to 25 have the highest prevalence of AMI, so 25.8%. Now, if you've done any research or you've heard any of these facts, that won't be surprising to you. But to a lot of people that don't have a lot of background or knowledge in this area, and there's nothing wrong with it, but we learn that that is the highest age group where the prevalence is. And then lastly, let's look at adults age 26 to 49 have a 22.2 prevalence as compared to those 50 and older, drops to 13.8. So why is this important? One, it affects a lot of people, right? Across the lifespan, but in particular our young people, 18 to 25 years of age. And that's why, we need the outreach to them and everyone affected who are managing a mental illness in their lives. And so when you first see these, you might be blown away and not really realize that this is happening. But these figures are just growing. And probably post-COVID, as somebody mentioned when they checked in, they'll raise quite significantly. Now, what are we talking about? For our purposes tonight, according to NAMI, which is the National Alliance on Mental Illness, they are across the country. They are the largest mental health organization that provides support and education on mental illness. So for our purposes tonight, I'm going to use these terms interchangeably, okay? Mental health conditions, mental illness. Now, there's many of them. We're not expected to be clinicians, therapists, social workers here. In my capacity here tonight, I'm hoping to provide you with some basic information that anyone can use. There are many different mental health disorders. Here's a few of them. Let's talk about the first category. So in left side of my screen, these disorders affect a person's thinking, feeling, behavior, and mood. And also, on the right hand, can deeply affect their relationships and their daily living, how they communicate, and how they function. Okay, so basic daily living or basic functioning. So you might have heard of many of these, right? There's anxiety disorders, there's depression, which is a low mood for a significant period of time. There's bipolar disorder, which can be, there's two different categories of bipolar disorder, 1 and 2. Some are hypomania, where there is a low level mood, right? That's consistent. And then with the other, there's instances of depression or low mood, and then heightened mood or mania. So again, just kind of take this in, just kind of don't worry about it. Again, we're not trying to be clinicians. Dissociative disorders are there as well. And that's when there's a break from reality, right? A person's perception of what their thoughts are, how they view reality may be different than you and I. And that one, it can be, not that they're all not serious, but that one can be very serious and lead to hospitalization very quickly. There's eating disorders or disordered eating, as you may have heard of it, where you're eating too less or too much, or restrictive or binge eating. It goes on and on and on, but I just want to let you know some of them. Post-traumatic stress disorder, either witnessing or experiencing a significant traumatic event. So even being a witness to something, an act of violence, an accident, abuse can be traumatic for someone, and they can be affected. There's a lot of symptoms for post-traumatic disorder, as in many of these, but a lot of people may believe that this is not prevalent, but it is. So you and I can be in the car driving down the road, and we can witness something that's horrific and traumatic, and our body takes it in. And what happens then is it's hard to speak about it. We don't really even maybe sometimes realize what has happened to us. Okay. With obsessive compulsive disorder, there's an obsessive thoughts, and then there's compulsions or the actions. For example, we may not think we turn the stove off, and we're constantly thinking about it, and then we're constantly checking it. Psychosis, also a very serious disorder. Again, a break from reality, can involve hallucinations or delusions, seeing or thinking things that are not actually there, and can also be a crisis moment and need an emergency response. And we'll talk about that more at the tail end of the presentation today. There won't be a quiz or a test, so no worries there. Schizophrenia also can have delusions or hallucinations, seeing or hearing things that are not there in reality. And also significant patterns of confusion. And it may not be the usual confusion that you and I may experience, perhaps if we go to the store and we don't know why we can't find what we're looking for there. This confusion is a little bit different. Maybe we forget where we live. Maybe we forget our name. Maybe we're talking and our speech is erratic, and we're talking about many different things that's garbled and doesn't make sense. So these are just some of the symptoms. And lastly, with schizoaffective disorder, what can happen is there's elements or symptoms of schizophrenia that I just mentioned. And also it's combined with mood symptoms, right? So these are just some ideas of the mental illness and the mental health disorders that exist. Suicide, I want to touch upon briefly. It's the 10th leading cause of death overall in the United States. And this is according to the CDC, and we've heard a lot about the CDC, Centers for Disease and Control, during our pandemic. So then you might ask, well, what does that look like? According to 2018 CDC report, claiming the lives of over 48,000 people. The second leading cause of death amongst individuals 10 through 34, which might lead to you asking, well, what's number one? Number one, according to the CDC, is heart disease, running closely with cancer. So suicide is up there. It's the fourth leading cause of death amongst those aged 35 to 54. So suicide can touch people's lives across the lifespan. And, you know, sometimes there's no warning. Tonight, I'd like to focus on the common warning signs in mental illness. And this is, again, according to my resource is the National Alliance of Mental Illness, or NAMI. 2021, hot off the press. These are not all of the symptoms for adults and adolescents, but these are some of them. And you might see some of them in my tip sheet that I also included along with your Zoom invitation, or Susan, I should say, included for you. So you see them here. We just mentioned suicide, right? So sometimes people think about suicide, they might have a thought, but that's where it stays, okay? They might have a thought such as, I don't want to be here anymore, it's too painful. Rarely, in my experience, do people say, I want to kill myself. But there are some that do. Majority are not as obvious of that, right? But that's the first level, right? The thought. Then there's the means and a plan. That means they know how they're going to do it, and they have the means. So for our purposes here tonight, they're going to take these pills, which is their plan, and they have the pills. Suicide is always a crisis situation. If any of those three are present, if all three are present, it warrants an emergency call or an emergency transport to the nearest emergency room. I want to make that, or 911, right? We know that, right? Bring the ambulance. We never want to vary when we're in doubt. When in doubt, I always say, call out. Take the person to the nearest emergency room. Better be safe than sorry, okay? Difficult perceiving reality. We talked about that a little bit. Not knowing where they are, not knowing their name, not knowing that things are not there that they see or hear. Extreme mood changes from low to agitated to anxious, excessive fear. Excessive is there for a reason according to NAMI, right? This is in duration, frequency, and extent. So the best example that I can give with that as a presenter, I always like to have practical knowledge of this, right? Is, they're excessively worrying about a lot of different things or one main thing, and it's constant. And it goes on in terms of duration, and it's frequent. All right. Excessive sadness and low mood, we've talked about that. Confused thinking. Prolonged feelings of anger and irritability. If someone's angry or irritable for a few hours, right, for a few moments, even for a whole day, you may want to observe that and then go from there. And then if it's prolonged in duration and frequency, then it becomes a potential warning sign. Overuse of substances, including alcohol and drugs, or self-harm, which could be a number of things. Could be self-injury, where someone is cutting themselves on purpose. It could be that they're hitting themselves in the head, which happens sometimes, or banging their head against the wall. These are all signs that someone needs some help. Someone needs some type of intervention, right? If they cannot carry out daily activities of eating and drinking and sleeping, or in many cases working, the normal things that they would normally do, it may or may not be an emergency situation, but it warrants concern and it warrants observation. And lastly, avoiding friends and social activities. And so someone who normally would take pleasure in something you find, such as gardening, doesn't anymore. Or you see a neighbor or a friend, and usually they're out every day, perhaps walking their dog, perhaps visiting you, and now you haven't seen them in a couple of days. So these are just some of the symptoms, and there's many, many, many more, but these are the ones that I wanted to share with you today. And in adolescence, sometimes it could be that they're irritable more than angry, or irritable more than anxious. So just be aware of that too. And so then we say to ourselves, and look at it if we're experiencing this in our own lives, caring for a family member, what's the impact? Well, all of you could maybe say more than me about that if you have someone in your life or a loved one or a friend who you are caring for or concerned about. There can be denial both on the person who's experiencing the mental illness and also the family member. So let's use that as our context, right? And so what do I mean by that? Well, someone could think that after maybe the initial diagnosis or the initial emergency or crisis that the person's doing okay, that they'll be fine and there's no follow-up care that the person needs. And while that may happen sometimes, with mental illness is usually long-term in duration. Somebody will need some support from perhaps a team of people for the rest of their lives, or for at least a certain period or duration. There can be tension in the family. And sometimes that comes in terms of caregiving and who's going to do this. And it could be because they don't know what to do. And that happens a lot, where they don't know where to turn, where the resources are. They don't have enough information about what may be happening for the person or what the diagnosis means. There can also be frustration and hopelessness. Perhaps the family member only has a limited time and would like to do more, but for some reason they can't, or maybe they have unlimited time, but the person who's suffering or managing the mental illness doesn't want anybody to know because of shame. And a lot of times people who are experiencing, not always, right? But a lot of times people who are experiencing mental illness or receive a diagnosis uh, may not may not want to look at that. They may feel like they themselves are a failure, personal failure, or they're reluctant to get help because maybe they feel that they can take care of it themselves. Uh, and so this whole reality of what it means to them and what it means to all of us who are coming up alongside to try to help. There's a stigma in society, that says, oh, and one of the things that I want to talk about, and maybe you all have heard this before, but if you haven't, um, if you've ever heard somebody say, oh, well, that person is schizophrenic or that person is bipolar, yeah, you want to be careful, right? Because that's part of stigma. That may be their diagnosis, but that's not who they are, right? So you always want to say that person is living with, managing, doing the best that they can with their bipolar diagnosis, or they're managing bipolar symptoms. They are not their mental health disorder. I hear that as a clinician all the time. If somebody does receive a diagnosis, we want to remember to refer to them as their name and that they're a person, right? And they are not their diagnosis. So that's really important here. And then when we're helping as a caregiver or helping as a friend, helping as a family member, there can be exhaustion and burnout, not only for the person experiencing mental illness, but then and trying to understand it and trying to make changes in their life and manage it, but then also for the person who is trying to help. Maybe it's rides that they're giving or helping with medication, or maybe they're working a full-time job and then coming after work or between their work schedule to help out someone. And maybe the person wants the help, and then maybe on the other hand, they don't. So a lot of times they're frustrated too, and then our frustration as the caregiver can meet their frustration. And then nothing gets done sometimes for moments, right? So that's where understanding has to come in, and listening skills, and we'll talk about that in a few minutes too. And just this awareness that it's a change in everybody's life that may include grief symptoms, sadness of the loss of who they used to be, what they used to be able to do, understanding what they're going through now, and feeling alone that they themselves don't know what some of the answers are or what some of the resources are to help themselves. Now, before I go further, I just want to see if there's any questions about what I said so far. And if you can help me, Susan, we're good? Okay. Okay, so then what are some practical ways? Now, if you did receive the email and the attachments, you will see some of this is an overlap with some practical ways, tips for how to help a person with mental illness. But I'm going to take you through some of those. And then if you didn't get it from Susan, please reach out to her and she will send you a copy. So first and foremost, in terms of practical ways, I want to start first with the relationship. If you are open and someone trusts you, then that's going to be the first practical step to take when you come alongside someone. You know, often sometimes here at the diocese, people call me that I don't know. or I haven't met, and they share confidential information with me and they ask for help. And even though I don't know them and haven't met them personally, we can never underestimate the importance coming up alongside whoever they are who needs help and support and asking them what's happening for them, listening, being open and understanding to the best of our ability, explaining to them if you're a caregiver or a family member or friend and you do know them, that I am concerned about you, I care about you, and I want to see what I can do to help. And sometimes when we ask that question, a practical way could be, how can I help? And sometimes the person doesn't know. They don't know what help they need. And even if they did, they don't know where to get it. Okay? So a lot of times it's beginning at that very first step of really joining someone and saying, okay, we don't know, but what do we do? What do we know? And we start from there, right? And we want to encourage, we want to support, and we want to share resources, share information. And if we come from a place of being open and listening to someone and they feel like they can rely on us and trust us, then we're more apt to help them when they have some difficult challenges or when they might push us away or be a little bit worried about what their next step will be. And so that listening and coming alongside and trying not to judge. Now, we probably all judge at one time or another. And it's really important that we do our very best to not in these cases. Here's an example. If you are a caregiver and the person is frustrated and you're trying to prepare a meal for them and you bring it, and this is just an example that I'm making up, and they push you away and they don't want the meal and they ask you to leave, it's more about what's happening for them than it is about what you are trying to do for them. Does that make sense? So taking a step further, you may decide to leave the meal and say, well, it's here if you need it, or put it back in the fridge and say, it's in the fridge if you need it. I'll stay a few more minutes and then I'll be back later. Then it would be to say, you don't care about the meal. You're not listening to me. Fine, I'm leaving. Now, none of us would do that, of course. But if we are frustrated or if we came from work and we're trying our best, we're human. So it could happen. It could happen to us. No one's perfect. So one of the things that we just want to remember that if that happens, we can always come back and say, well, I'm sorry. I got frustrated. What was happening for you? Did you really not want the meal? Did you really want me to leave? What's going on? And hopefully the person says, well, when you come back later, I'll tell you what's been going on for me right now because I don't want to talk. Okay. So these important things about practical ways. Let's say you say, well, all right, Val, that sounds great, but I really don't have a trusting or open relationship. And I'm making an example again with my aunt. And I'm trying to do my very best. And I'm doing this and that for her. And she's been agreeable, but sometimes she just doesn't seem to appreciate me. Okay. Well, that's when you have to work on building the relationship, building the rapport. And that's when you can bring in some other people, right? Some other family members, some other friends of your aunt, some other medical professionals, and you start to align your team so that they can help you, right? And it doesn't mean that you don't have an open and trusting relationship. It just means that right now you need a little bit of support and the aunt needs a little bit more support than one person. So the clue is to try not to take it personally. Try to say what you can do and what you're not able to do. And do your best in getting your own support too. Because if you are helping somebody or caring for someone, it can be quite a load. So there are some support groups. Nourish for Caregivers is one of them. Online since COVID. They will then move back in person. There's parish groups and support groups. There's NAMI, who I already mentioned, that has a hotline that I'll give you at the end. So I'll give you all of that. And it's also in some of the forms that Susan sent you. So biggest point here is checking in with them, maybe asking about the garden, maybe letting them know you haven't seen them in a while. Is everything okay? And say it in the positive, right? And because we don't know if it's an emergency or a crisis yet, and it very well may not be. So we just want to start to have that conversation and build on that relationship. Listen carefully. Listening means we don't have our agenda running as much. We don't think about solutions for the person. We're listening first and mirroring back what the person said to us. We're reflecting back what they said. It's hard to do. It's a tough practice. We all can listen though, but we all can learn how to listen better, including myself. And I work on this every day, all day, right? So we always want to have forward body movement, eye contact, welcoming stance. We don't want to tower over people, right? We don't want to stand over their shoulder. We want to come at their eye level. We want to sit down. We want to lean in. And we want to say something like, tell me how it's going. Well, it's going. Okay, thank you. Let me tell you what's happening for me, right? And we can start there. We can talk about baseball. We can talk about church. We can talk about school and work or gardening or fishing or a TV program. And then eventually we work in our concern. Please try not to push too hard. So if you find that you're pushing too hard and you're overwhelmed and frustrated and burned out, you're usually working too hard and you have an agenda that's into solutions, perhaps. And that can get in the way. It's all good in its own time. And if you've asked the person if they would like a solution and they've said yes, then by all means, go ahead. But don't forget to ask, because that's very important. And remember, caregiving or helping someone with a mental illness and managing it is about support, not about control. Ultimately, if the person is managing their mental illness and is not in the hospital, it's up to them with your information that you share and your support to take the next steps in their own life. I want you to express your support out loud, learn as much as you can about the condition that they have or that you have. I want to encourage you and for them to seek help and support. Friends, family, support group. I have a whole screen coming up that talks about support. And if there's a treatment plan in place by the medical providers, you want to understand what that treatment plan is. If you're working closely with someone, you can ask to review it with them. Perhaps you're writing it with someone and their caregiver and their medical physician or support team or their social worker or their therapist. A lot of times family members or friends are involved in the medication plan, right? And so it's important to understand the treatment plan as much as the person will allow you to, and help them, assist them following it. For example, there's plenty of people today that need help with their medications, like I mentioned. Some have pill boxes, some have caregivers, some have nurses' aides, some have friends or spouses that help them take their pills, count their pills, fill their pills, understand their pills and why they're taking them, and the importance of taking them. So it's very scary for someone who's managing a mental illness who might have 3 or more medications to take, sometimes up to 20 medications to take. It's daunting. So whatever help you can provide, or maybe they're taking one and they can do it perfectly by themselves, but that's part of that treatment plan. And so if somebody doesn't have one or starting one, you can be a great advocate for them. And since we are persons of faith, it's important to seek some support. A lot of people go straight to their pastor, straight to the parish nurse, straight to a pastoral counselor. I'm not saying everybody, but many, and ask for help. And these persons are able to provide the support or the resources or the referral or the recommendation, or be there, most importantly, for a listening ear and guidance, right? Friends, parishioners, our parish family and parish community are key. Our school, our employer, we're our work community. So everyone can come together to support one another. Prayer offerings, prayer lines, prayer services, prayer chains, mass, adoration. If anyone here needs a 24-hour adoration across the country, in particular, there's one great one from Poland, then let me know, let Susan know, I'll send that to you. It was really helpful to a lot of people during COVID who called into the diocese. You may need it for yourself, or you may know someone who does. And so Bible study, now that the parishes are starting to open up, some of the Bible studies are returning for people who just require friendship, support, biblical support, scripture. And then most importantly, peer companion support groups too, right? Nourish for caregivers, like I mentioned earlier. Perhaps you have your own support group that's in your community or in your parish. Maybe you attend already. NAMI has various groups, and I will take this moment to let you know that NAMI will be making a presentation in August. I will get the date to Susan, and she will send it out, hopefully, to you, all of you, because they will be speaking and telling about their services on behalf of myself and the Office of Family Ministry coming up in August. So if you feel like you need that, and they'll be that will be the second activity or event under the mental health ministry grant that we received here last year, and we will have 6 to 7 more after. So I just want to let everybody know here that you're not alone, and nor is the person that you care about. How's everybody doing? Any questions at this point? Okay, we'll press on. So let's talk about those handouts. I hope everybody can raise your hand. Did everybody receive them? The first one was navigating a mental health crisis, preparing a crisis plan. And you can get these from Susan, no worries. The second one is the signs of suicide, warning signs. And the third one, warning signs of a mental health crisis. First and foremost, I want to highlight these 3 key points across all 3 of those handouts, okay? It's on one, but I consider them key for all 3. And the first one is to listen, like I mentioned already. And here's an example of what to say. I care about you and I would like to help. If someone is not ready for help, or maybe not ready for that back end of that statement, I care about you is a good way to start. Expressing your concern. I'm concerned about you. That's key. Maybe we all are, right? But we don't say it out loud. And am I still good? Am I still loud enough, Susan? I know we're recording, but it's important for you guys to hear me. So I'm concerned about you, and I want you to know that there is help. I met a young man, not a client of mine, so nothing confidential, not even through the diocese. And he shared with me an accident that he was a witness to. He was in the car at a high speed, and there was an accident that occurred. And now he's older, and he's thinking about what should he do. It still bothers him. So he's thinking about how to get some help for that, right? And so a therapist who specializes in that traumatic situation can be useful to him. So I provided him a mental health referral. Not me, but someone else, right? Who I knew could help him. And I do hope he calls. I did encourage him. It's his decision. I may never see him again. Herein lies my point. I listened, expressed concern. I want you to know there's help. So I use the back end one, right? And then, if it is somebody that you know, you want to reassure them. You are important to me. We're going to get through this together. Now, I wish the young man well. Still reassuring. But I couldn't say the second half, right? But I encouraged him to work with the future therapist to get through it. Listen, express concern, reassure. Always helpful. It wasn't a crisis in the example I gave you, and yet it could easily become one over time. So we never know what seeds we're going to plant, who's going to come into our path, cross our path, and what words we can say, even one or two, that can be helpful. So let's talk first about what to do in a mental health crisis. There's three things we want to look at: danger, time, and emergency. So danger, real important, right? You need to assess if a person is in danger, not only to themselves, but to others or to the property. Well, how do you do that, Val? Well, are they communicating to you that they're going to harm themselves? Are they communicating to you that they would like to harm someone else? Do they have the means? Do they have a plan? How you assess danger, okay? Time. How much time do you have to respond? So if someone hasn't come out of their house for a couple of days and they're a neighbor, and you go over and they answer the door and they come out and you take a walk around the garden, is it an emergency? No, yes. They're talking to you, you're having a conversation, you find out they've been eating, they've had visits from their children, and they're doing okay. It's not an emergency. Plenty of time. On the other hand, they don't answer the door. You knock on the window, you have their phone number, you call. There's no answer. You have less time now. Okay? We don't know what the situation is just yet, but we don't know what's going on. If you don't know this, as a private citizen, you can always have a wellness check. You're going to call the police department and you're going to tell them that you need a wellness check. They have not seen your neighbor in 1 to 2 days. They will come, they will knock on the door, they will help you. Obviously, if you enter, the person is on the floor, they have a medical emergency, you're going to call 911, you're going to act right away. You always want to call 911 first, and then you can call the family members if you have it. Time is of essence in that case. And now emergency, right? The third one. I just alluded to it in my example, but in the case of earlier where you're walking with a neighbor in the garden no emergency assistance was needed. In the second scenario, emergency assistance was needed. If you need support to get help, take somebody over there with you. If you have a sibling or a friend's number of the neighbor, you can call them first and go over there with them. But you always want to consider that time. And you always want to consider, what is the next best step that I need to take? Okay, so you want to assess these three, always when it comes to a mental health crisis. These are things that you can do. These are resources for you and immediate help in the crisis. Okay, 911. Here's the NAMI helpline, National Alliance for Mental Illness, 1-800 number. They have trained persons that will answer that phone, that will help you immediately. This is suicide concern and suicide crisis. Here's the National Suicide Prevention Line for you. So it's 800-273-TALK, and I have the other numbers there for you. Also, in the age of texting, there's a crisis text line for NAMI. So you text NAMI to 741-741. And then if there's a substance abuse and mental health helpline, we have the 800 number there. Now, sometimes I'm asked, well, Val, which one of these do we do? Well, it's hard to know, right? However, if we're working with somebody and we know their condition and we know their medications and they're perhaps living with us or living next door to us or a family member, right? We may want to call, and it doesn't need the 911 right away. We might want to start with NAMI. 911's up there in the number one place for a reason, right? The goal is that we don't, here's the good news. If we think it's an emergency, it probably is. So when in doubt, call out and let the professionals decide. And that takes the pressure off of you. I have had to do that, both in my ministerial work and also in my clinical work. And it's always been the correct decision. Okay. So those are just some resources. There's many more, but these are some. There's also, your local county health department will also have a crisis line. So wherever you live and are watching from tonight, they will have an 800 number for you that you can call in your county. And all you have to do is punch in your county crisis line and it'll come up. So whether it's DuPage, Kane, Will County, etc. So before we go any further, and we're doing really well on time, some of you have looked through those handouts. Some of you know a little bit more now. Tell me, explain to me what you're thinking. What kind of questions do we have? What stood out to you in your tips for how to help a person with mental illness? Be respectful, talk to them in a space where they feel comfortable, listening, try not to push too hard, those things that we talked about. What's coming up for you? And I'd like you to share some stories, if you can, how you've been successful in helping anyone manage mental health or mental illness. What questions come to you before I go any further?
Valerie, I've taken the mental health first aid course that was offered by Edward Elmhurst Hospital, and they have a little, do these things, assess and all of that. But one of the hardest things that we were encouraged to do is ask the question.
Yeah.
Do you want to hurt yourself? Are you thinking about actually speaking that out? And that's really hard. Mm-hmm. It takes practice and thought ahead of time. Absolutely. To be able to ask that question of somebody that you care about.
Mm-hmm. Mm-hmm. And what before I say anything more about it, Susan, what has helped you? And have you been successful asking it?
In the class, we had to role play, and that was really helpful because you were pretty much on on the spot to speak it out, and actually get those words out of your mouth. But yes, I have asked others that question, and it takes a lot of pressure off when you hear the answer. Because for me, thinking the worst and trying to anticipate the worst outcome is hard. It's hard to see the rest of the ways to help if you're worried about that one big thing.
Absolutely. So, if we, to your point, if we look at the warning signs of suicide on the second handout, I believe it was number 2. So the warning signs of suicide. Let me go through those, okay? So collecting and saving pills, making or changing a will, saying things that nothing matters, you'll be better off without me. These are all from NAMI. Giving away personal possessions, withdrawing, increasing drug or alcohol use. It's very hard, as Susan has mentioned, if you're observing all of this, right, then in a way, our body doesn't want to know. Our body doesn't want to know if it's this sometimes or what it is, because we're afraid, right? And that's a human reaction, a human response, and very normal. But actually, if we can think of it this way, what I found helpful as I present is sharing with individuals that the more information that you have, the more resourceful you'll be able to be for this person who really is hoping that you will ask. Because in many ways, either known to them or unknown to them, they are having these behaviors, right? They are experiencing these symptoms. And whether that they know that you observe them or not, they really are looking for help in many cases. And so I like how they put the 3 on the sheet. And I like them so much that I'm going to say, and there's all kinds of different versions for this. And I've been asked, even in the mental health class that you're talking about, well, what if we say, how are you feeling tonight? And, that's a good start, okay? But it's better to say, are you thinking about suicide? Do you have a plan? Do you know how you would do it? The thoughts, the means, and the plan, okay? And sometimes it's one of these questions, right? It might not be all. And sometimes you ask one and you find out it's the thoughts, but then it's no to the other 2. And you say, okay, now, how long has this been happening? And what can we do to help you? I'm concerned about you. So you're listening, right? Now you're expressing your concern. Now you're reassuring them that there's some help. Now, getting it out of your mouth is the hardest thing, right? So you do have to prep the body, right? And how do you do that? You do that by knowing yourself ahead of time or even in the moment of saying, what's happening for you? I'm noticing some changes. And I'm just wondering what you're going through. And then you wait, okay? So remember that we're looking for danger. We're looking for if there's an emergency assistance that's needed. We're looking at time. But we're also looking to see if we can build on that trusting and open relationship that we have with that person. Here's an example. Here's a children's example. Children will sometimes say, I'm very angry and nobody likes me. And I'm too much trouble in my family. I should just go away. These are just examples. Okay. What do you do with that? Do you say, are you thinking about suicide? Do you have a plan? Do you know how you would do it? No, because they're a child, right? So it's a little different. I'll give you an adult one too, so adult example. With the child, you say, whoa, those are some big emotions. Tell me more about it. Sounds like you're really upset. Got a lot of big feelings. Tell me more about that. And then you find out they don't really want to hurt themselves. They're just really upset with really big emotions. Now, sometimes that happens with adults, and you can use that same example. Wait a minute, what's happening? You're usually not like this. Let's sit down. Let's have a cup of coffee. Let's go get some breakfast. How about some lunch? And why don't you just update me with what's been happening in your life? Let's start with something positive. And then they come around, a lot like my image, right, over coffee, to tell you what's been happening, to tell you what the big emotions are, to tell you what the frustrations are. And then somewhere in the middle or towards the end, you come in and you say, now, you can start out with, are you thinking of harming yourself? Right? Have you had any thoughts about suicide? Oh, no, it's not that bad. Or, oh, yes, but that was yesterday. And today I'm better. Okay? So then you start gauging it. And again, since we're not clinicians, that's all we can do is our very best. And then if we need to get support, like the training told you, right? In your training, the mental health first aid. And I do advocate for that if you haven't had that. Linden Oaks, we will have another one happening here in the fall. So I can let Susan know about that too. And it's a really good one for anyone of any age to have that knowledge. One of the examples that they use in that training is a neighbor seeing someone not doing well, and then the person not really wanting any help. And then the person sat on the steps and called the hotline to get some support and to get some referrals and to get next steps to help. Person wasn't suicidal, but they went that extra step, right? And just know that with suicide or suicidal ideation, a means and a plan, you don't need the person's permission to call 911, to call the helpline. A lot of people don't know that, okay? I mean, in a perfect world, we would like to have their permission and like them to go along, but in an emergency crisis, take this step for their health, okay?
Valerie,
Yes.
has there been research on whether mentioning suicide to someone in a sensitive position would respond more positively to the idea of perhaps being planted in their mind?
Yes, there is. However, I'll have to get that to you. It's readily researched and documented that it does not encourage someone to have suicidal thoughts or
Okay.
with suicide. So it does not
Thank you.
encourage that.
Okay, thanks.
Yeah. So get help immediately. Call their therapist, their medical provider, 911 if you need to. Remove any potential means. And you're going to call the hotline if you need to. So it's really hard to keep your voice calm, right? You see that on all these handouts, right? Most people sometimes scream, especially if it's a family member or someone close, okay? So if you feel like you're going to scream, then you need to get somebody else in to help, right? Don't leave someone in crisis. Get someone else to make that call. So let's say this happens and you're at a concert or you're at church and someone falls down and it's an emergency, right? Okay, if you're the first person on the scene or the first one in that pew, right? And you're able to do it, so you stay with that person, you call out, call 911. Person, the rest of the community, probably several people are calling 911, right? And getting that person there. You can be in the middle of the street. You could be in a car and witness something, right? So you can always play a role as you're able to, okay? If you can't, if it's too upsetting for you, maybe it is a trigger for you, then have somebody else do it, okay? And remember, then the professional will help you. The professional will give you some support. So you don't have to do it alone. I want to point out the warning signs of a mental health crisis, the third handout. I want to point out, avoid touching the person unless you ask permission. That's really, really important, especially if somebody has had a trauma. You don't want to put your hands on someone. Now, for us as pastoral ministers, many of us, or, you know, just human beings who want to help, we may want to do that. But that somebody might be in pain, or someone might be triggered from something previous, or someone may be startled by that. So you want to avoid touching them and offer options. So that's big, right? And then lastly, on this crisis plan, I do want to talk about this. Crisis plans, you want to, if you're playing a role in helping somebody, you want to help them make that when they're feeling okay. So in other words, when things are going well, okay, you're not going to create a crisis plan in the middle of a crisis. But over time, right? So let's say no crisis has occurred, or a crisis has, and you're having a plan for a potential future one. So you want to collaborate with the person, experiencing the mental illness, and also their loved ones, caregivers, friends, and professionals in their life, and understand their medications, understand their treatment plan, understand who are their support team, and what is their general information, right? So a lot of people wear, alert bracelets, or they have different monitoring systems set up in their houses. Some people need that. Other people don't. Safety plans is also on here. A lot of people don't know what that means. A safety plan would be something as simple as, when you are feeling overwhelmed or anxious, or your symptoms are increasing, who are the top 2 to 3 people that you can call? What are the top 2 to 3 things that you can do? So for example, I can take a walk, I can play music, I can read a book, I can call Sally, my doctor, or my therapist, Joe. And then part of that treatment plan or safety plan is encouraging individuals to have those numbers in their phone, to have those numbers on their fridge, to have them with them, on them, so that they're not scrambling, right, as the symptoms start to escalate. And then they start to take those steps that they know well and maybe practice those. And so, once again, there's things that we can do. To recap, we can help somebody with a safety plan. We can help them build a crisis plan. We can be very careful with what we say. Here's some things to avoid saying if you receive the tips. I'll pick out the top 2 things to not say. You just need to change your attitude. You have the same illness as my friend. Just pray about it. Now we know prayer is good and prayer is healing, but saying something like this in a crisis situation is not helpful, okay? And we want to not do the following. Tell somebody that they're not listening, blaming them, taking control, talking too much, assuming that we know what's going on for them. Even if we have the same mental health disorder ourselves, our experience is different than someone else's, okay? Being sarcastic. Sometimes we do that, but we don't mean to. We just don't know what to do. It's best, and I say this a lot of times, or often, is it's best to say, I really don't know what to do. And I really don't understand what's happening, but I can join you and we can try to find out together. And so that way the person knows that you're with them and that you don't have all the answers, but you're willing to help them navigate their challenges and find a way to manage what they're experiencing in a positive way.
Valerie, you said something that made me think about crisis situations, and not all crises are mental health crises, but our family members, our loved ones who are challenged with mental health or other health problems and are taking a lot of medication. It's really good to have that at hand. Emergency response professionals will look for it on the fridge. They will look for it on the fridge. It's like almost a universal thing. And it's really hard to think of it when you're the one that's there trying to help someone in crisis, to think about the 2 or 5 or 7 or even more prescription medications and what the dosages are and all of that. It's a little bit of work to keep it current, but it's certainly worth it in a crisis that you can just say, here it is.
Exactly.
All written down.
Exactly. And very good point. Finally, what I would share is if you notice these symptoms, right, that you would hopefully have the list of medications to be able to tell the physician that you're calling, or the emergency personnel that you're calling, or the psychiatrist or the psychologist that you're calling for help. You're going to have a copy of whatever their current treatment plan is, or their current safety plan. You're going to be able to describe the symptoms that you have observed and the concerns that you have. Now, if you have it already at your fingertips, a lot of people, right, have it already typed out, like you're saying. And if you don't worry, you can get it, or maybe the person has it for themselves. But in an emergency, when there's a lot of things going on, it's hard to even remember all that, even though if you're giving out the meds each day. So it's good to know what you can do. The other thing is to think about what other medical conditions the person has. For example, do they have diabetes and asthma? Have you observed trouble breathing along with the mental health symptoms? So what are the other medical conditions? Or are they undergoing current treatment, chemotherapy, some type of treatment at the time of the emergency or the crisis, or just even in their daily life when you're talking to them, right? And so the more that we're aware, the better off we can be to be a resource and support and encouragement to others. So at this time, any other questions that come up as you think about what we've gone over today?
I have a question.
Okay.
In all your examples, you sort of talk about the need to be conversant with the person and so forth, or being willing to talk to. Some of the different types of mental illness make people really, really withdrawn, and you can be a loving relative, and it's really hard to get that person to say more than a couple words or something like that. And all your stories and examples were right on the spot as I could see, but I'm trying to see, how do you get that relationship to begin with, where that person feels comfortable with you, and you're feeling comfortable talking to him.
Yes, very good. Thank you for that. Well, very good question. Excellent. And this is what I would offer. So yes, if you can have a conversation with them, if you can have that back and forth, that's ideal, right? But you're exactly right. So sometimes it's 1 or 2 words. Sometimes it's silence and gardening. Sometimes you're just going over and you're having a cup of tea and you're just listening. Sometimes you're listening to music together. If I look at my COVID-19 experiences that continue till this day, sometimes it's saying to the person, I'm here with you, and you don't have to say anything at all. I'm just here to be with you. Sometimes it's laughing together. Sometimes it's you sharing a story and maybe them just listening. or nodding. So we can't underestimate body language, right? Our body language, if we don't know it, is 96% of our language. 96%, everyone, are nonverbals. I'm sure you've seen a lot. People call me animated. I'm sure you've seen a lot of nonverbals from me tonight, right? So I could be maybe a little bit overwhelming if I encounter someone who is in a depressed mood, right? So I have to change a little bit, not so much my personality, but I don't want to overwhelm somebody. So I might come up alongside and say, I'm here. So glad to be here. And I just want you to know that you don't have to say anything today, but I'm here. And maybe we can watch a movie or a show. Or what would you like to do today? Would you like to draw? If I think of my ministry examples, I could go on, but we only have so much time, so I'll only give you one. There was a gentleman, I want to say, I don't know for sure, but I want to say that he was in his 80s. And he came to the diocese for a memorial mass. And he was very quiet, right? It was a mass. But we did have a reception afterwards where everybody was talking afterwards. And he waited until he was one of 4 people left. And he approached me in the hall. And he said, do you have time? He said, I don't really talk that much. And I said, sure I do. And I could see, he was friendly, but only saying a few words. I had no idea. This is what happened. He opened up his wallet, took out a picture of his wife, told me the story of his loss, and told me different stories that he remembered that were important to him. And before I knew it, an hour had gone by. I did nothing but 2 things. What did I do? Listened. And I said, yes, I do. I have the time. He told me at the end, he had never told the story. He told me at the end, it was 20 years since his wife had passed. He told me at the end, thank you so much for listening. So we come up alongside and we step back enough to let the other person come forward to say something or to say nothing. They know we're there, even if they're not feeling well, even if they are depressed, even if they are having a low day, a bad day. They know we're there. Our presence makes a difference. We can leave a note, a poem, share a song. Just sit and make eye contact and let our nonverbals take us there. Does that help?
Valerie, in my experience, it seems like the messages that are welcoming, accepting is, I don't want you to be different. To say to the other, I don't want you to be different. Well, however way you say it. I'm accepting of you. It's if you need help with what you're struggling with, we can work on it together, but I don't want you to be different. And sometimes that's hard if there's behavior and it's difficult to communicate. But for me, that message is the key message. I don't want you to be different. It's you I want to spend time with. It's you I'm here for, and it's hard. It's not easy, but that's a key message, a message of acceptance.
Mm-hmm. And very well very, very good point in that. How do we do that, right? And we do that in many ways. Like I'm sharing and like you're sharing, our nonverbals are what we do say. And then how we offer our presence to someone, even if there's nothing that we can do for them, or we think there's nothing that we can do for them. Because in many cases, to your point on the other end is, many people do feel different. they do feel that stigma. They do feel like there's something wrong and they don't fit in and they don't belong. And what helps me is letting them know that in my presence, right, everyone is welcome, right? Every story is welcome, and that any diagnosis or any condition, whether mental health or otherwise, doesn't define the person, doesn't define them. And we don't say that, right? We don't go up to Susie and say, Susie, your diagnosis does not define you. But what do? We say, Susie, I'm here for you. And no matter what happens here, we're going to figure this out. We're going to figure it out until you feel a little bit comfortable, or you're going to let me know what you need and what you would like me to do and what you don't want me to do. And we're gonna really empower one another, right? I'm gonna really, it's not so much, sometimes, you know, with caregivers, you know, sometimes people may say, well, you know, I've got to do all this. Well, you know, that can be overwhelming sometimes, right? So you need to work with that person and see what help, like we were saying earlier, what help do they need and what can they do for themselves and what role you can play in it. You'll be surprised. People can do a lot for themselves, right? Just in general, each person, right? If we empower them and come from that place. So, good point. Anyone else?
One question that I have, or problem I run into, I'm grandma. I'm a different generation, and I've got teens. And they run to other teens to talk about what's going on. They don't come to me, and I know there's something going on. And it, you know, the only thing is that when it comes time to come home and they have a need, they come to me. Grandma, can I come live with you? Can I stay with you? I feel safe here. But they don't talk much about the other problems that they're having. I think partially because their parent told them that that's not something for me to handle. So how do I overcome that? Or do you have any suggestions there?
Well, and maybe we'll have to do something on teens though too, Susan, because it seems like there's some teen questions here in the future. So we'll see. But, you know, I hear you. I want to acknowledge you first with that. And, you know, a lot of teens, they do exactly that, right? They confide in their peers of the same age. And then they also follow the rules, most of them, right? And guidance of their parents, right? And so how do we do that? How do we honor those?
Both of those and yourself.
Those truths, right? Those realities. We honor it, and we also make ourselves available, and we also remind them, you know, I'm here for you.
Yeah.
I'm here for you. I can, you know, if you ever need to talk to me, in other words, we leave the door open for them and we let them know, so that our hope would be that if we're already doing that, it sounds like that you are, right? But if we continue to do that and we continue to remind them when they really do need your help, or, you know, it's a really serious situation or even a crisis, they will come to you because your door has always remained open.
Oh.
Yeah. And you can even acknowledge that. You can say, you know, I'm glad you have friends to talk to. I'm glad you bring those to your parents. I think that you should. And if there's anything that I can do to help you, just know that I'm here for you as your grandmother.
Yeah.
And I'm here to support you along with your parents and along with your friends. So now you've aligned yourself as part of the team.
Yeah.
That's what I would say.
Okay, thank you.
Okay, well, it's 8:01. If there's no other questions, I want to just really thank you so much for being here.
Thank you.
Thank
I
you.
know it was a short period of time. You're welcome. But again, we can only do so much in the time that we have, but I hope that there was some nuggets of wisdom or some reminders, refreshers for you that are helpful to you. I just want you to know that if there's any way that I can help you or be a resource for you here in my capacity at the diocese, please feel free to contact me. I'm in the Office of Family Ministry, the Associate Director here. And if you need any of those handouts and you didn't get them for one reason or another, please email Susan, and then she'll be able to get those to you. And maybe, I think she'll have an evaluation, right, Susan?
Yes.
So in the
Yes.
evaluation, maybe I'm just thinking about this off the top of my head right now. Maybe you can put my contact information there.
Sure.
And so that way they'll have me. And again, I try to help in whatever capacity I can. So, and if I'm not able to, then I'm able to give a referral, hopefully a recommendation, or at least some support to help somebody. And remember my examples and stories shared, right? We never know who we're going to encounter tonight or tomorrow. So just be open to that, the listening ear.
Thank you.
Thank you.
So I invite you all to join me now in our closing prayer. In the name of the Father, and the Son, and the Holy Spirit.
Amen.
I don't have it up there on purpose. It's just like you to close your eyes and just take it in. Life can be short, and we may not have much time to gladden the hearts of those who travel with us. Let us be swift to love and make haste to be kind. As messengers of faith, giving hope and confidence and peace. Know that you are blessed today by God, the creating one, by Jesus Christ, the redeeming one, and by the Holy Spirit, the sustaining one. Amen.
Amen.
And that prayer was written by Robin Kempster, a parish nurse. We thank her for sharing it with us.
Thank you so much, Valerie, for being with us here. Thank you to all of you participants, all of you who clicked into this Zoom presentation this evening. I will be sending you an email to follow up. I will attach those handouts again to that email, as well as sending you a link for an evaluation and including Valerie's contact information. And I'll probably put in that email a few of the links to upcoming programs. We have a mini retreat coming up on poverty in our lives. I'm going to be doing something on midlife spirituality in the month of July, and a few more really great Zoom presentations in August. So I will send that information to you this evening or tomorrow morning. And I wish you all a good evening. Thank you so much for joining us.
Thank you all.
Thank
God
you.
bless you.
Thank you
Bye
both.
now. See you again in my travels.
Good night.
Okay, night.
Good night. Bye-bye now.